All right, I'm going to get started. And hopefully y'all can see my screen.
Yep.
Excellent. We're here today to talk about the CMS 2025 final rule. Called this an initial read, but honestly, it's much more than that. And I'm here. I didn't think Kate would be with us, so I didn't have her on the list here, but I've got Patty Harper, Kate Hill, and Mark Lynn, who all of you, of course, know, to help us sort through this really very large number of changes, consequential changes that are pretty exciting. So let's dig in. You know me, the picture's getting a little old. I need to update that. And I get to plug North American here because we are a billing company. We do raw health clinic implementations, mock surveys, biannual evaluations, anything you need for your raw health clinic. And any of the folks on this call can help you with most of your raw health clinic needs, even though Mark is supposed to be retired, but we'll talk to him about that later. We also hear what we do at North American is always informed with our accountable care organization, Rural Advantage. Some of the components we're going to talk about today have big value-based care, quality care implementation implications, and we will touch on those. So if you're interested in ACO that knows a lot about rural health clinics, come talk to me. Let's dig in. The earth shook, yes, prior to the election for those of us that are healthcare geeks, because we got our final rule released that we've been waiting for on November 1. Now, if anyone is suspicious of the timing, be so, because of course, yes, this dropped right before the election. We have to put this caveat on it. I say this as a nonpartisan. It is bipartisan to come in and void or inactivate or whatever you want to call it, the final rules put in place in the last days of any previous administration. So we may need to be vocal about our support that please don't void these rules for us. They're very important. We will put these slides out on the Facebook page. I'll email them to whomever wants them. Notice over here on the right-hand side, we have the fact sheet, the news release. It gives a summary, and of course, it's hyperlinked. The summary is, of course, different than the actual final rule. If you go look for the final rule on the CMS website, you will not find it. The final rule is out under the Federal Register website. So if you get here, you know that you're on the fact sheet. If you get down here, you know you're on the actual final rule. Now, many of you that know me know that I've studied language. I've liked to study language, and who knew that my study of languages would prepare me for a career in Medicare speak? But here we are. So we have also a Medicare physician fee schedule final rule, but we also have an outpatient prospective payment system final rule. That part includes the intensive outpatient program rate setting that we're going to talk about, and Patty will discuss with us in a little bit. My presentation is based 100% cut and paste from the final rule. I started to talk about my study of languages, and this is where I had hoped to be, because what we do as consultants is we take text like this and break it down into discernible bytes that we know what to do with. This final rule is lengthy, it's complicated, and look, see the italicized part? Only part of it applies to rural health clinics. This is just in the summary of the final rule, but it contains all of the elements, of course, in the final rule. Now, what we do as consultants, we come in and we're going to break it down for you so we can start to do something with it. So this is the exact same thing It's just the different components pulled from the fact sheet of everything that is built in to this final rule. So not only is this enormous for us, it's enormous for a lot of different sectors in healthcare today. Look at that. We're only a small piece of it. So everything we're going to talk about are the rural health clinic and FQHC pieces. But again, it's only a small part of what's included in this final rule. Let's talk about the RHC-FQHC implications. Can't seem to say that word today. Care management services are totally overhauled. Totally overhauled. We have a new type of service that is a care management service. It's not time-based, it's risk-based. Advanced primary care management. We're going to go in depth into those. G2025 has been extended. We're going to get paid for our flu and pneumo shots, a couple extras too. Not on the cost report, but on claims. RHC productivity standards have been eliminated. We've got a clarification on dental services being encounters in an RHC. FQHC payments, market basket have been updated. We have lab services removed from our conditions of certification. We have clarification on primary care services and that nasty 51% primarily engaged in primary care problem. And finally, we have intensive outpatient program service clarification for us in RHCs and FQHCs. So it's dense. We've got a lot to cover. So let's roll. The first thing we have, and part of historically why rural health clinic status was important, is because it insulated rural health clinics from fluctuations in the Medicare physician fee schedule. Back in the day, even before Macron, I was trying to come up with the acronym, and for the life of me, I couldn't. We used to get all these Medicare physician fee schedule cuts that had to be postponed and put down the road, and the rural health clinic program was insulation against that. We don't talk about that as much anymore, but here's reiteration of that issue because the Medicare physician fee schedule has been reduced by 2.93%. Now consider that we've just gone through a period of inflation where inflation is supposed to be back down to 2.1%, but we've reduced the physician fee schedule amount by almost 3%. So obviously there's a disconnect there, and this informs why we're on such razor thin margins, inflationary pressures and reduced reimbursement. That is a horrible combination. It's where we live though. So that's what we've got. FQHC market basket has been revised. And I am just going down now in the list of everything as it appears in the final rule. I'm not going to read all of this to you. The FQHC market basket is a very long section, and it talks about all of the different components and how they were repriced and updated. And that's how the whole final rule works. They go through every single component of this to promulgate this rule. So the market basket for FQHCs gets updated every 4 years. It's most recently been updated based on a 2017 market basket. The market basket for us in the RHC world is here are our most common services that go into our payment codes. And here's how they get priced. Here's their cost weight. And it's a price index for FQHCs. So we've adjusted that market basket revision to 2022, which resulted in, you see at the bottom, a 3.4% increase in the market basket. So there you go. So FQHCs have gotten a 3.4% raise, while the rest of the Medicare physician fee schedule world has gotten cut 3%. Now, as rural health clinics, with our rate modernization, we get kind of the same insulation as FQHCs because our rates don't get cut. We're eligible for our cap every year, plus that MEI when it achieves stasis in 28. This is the big change we've got. And I'm not going to read through all of this material. Here's a brief history. For our purposes, care coordination and care management are the same thing. Remember, we got care management back in 2015. There were a number of problems with it, but care management has been updated over the years to include additional services. We have this G0511, which is this basket code based on national average non-facility physician fee schedule payment rate for all of the items that go into the G0511 basket. And that G0511 is what we use to bill everything. And it doesn't matter what service, we get paid the same thing. Most recently was, call it $72. 2024, we got remote monitoring and a number of other services added. So this G0511 was a simple average. So the more we add services to the denominator, the lower the payment rate was going. That was problematic. So now we don't have that problem anymore. There were other concerns about transparency. What's getting billed with G0511? How do we track what we've built with G0511? And we don't have any ability. A lot of times our care management services exceed our 20 minutes and what we're being paid for, and we can't report it. So now we're being underpaid because we can't report add-on codes. G0511 is gone, effective 2025. G0511 will no longer be used. And we're going to build the individual codes that make up that basket. I'm going to list out those codes for you momentarily with suggested or with projected payment rates. We're not going to build G0511 for care management, but this doesn't go into effect until July. We can start billing our individual codes in January, but G0511 will be effective after July 1. G0511 will not be billable. As I just said, because we're going to revise this, some of our services, we may have a reduction because that's what the fee for service payment is. It's lower than the G0511 $72 payment. For this reason, CMS approved add-on codes. So now, instead of just one line item, regardless of what happens, if we get care management and then our staff spends an additional 30 minutes over the initial 20, we get to bill it now. Before we couldn't. So I think this is a net gain for us if we use the program correctly and our coding correctly. Our payments are going to be on a national, the non-facility fee schedule. So when you go pull the fee schedule, remember, don't pull the one with the hash code next to it. I still call it a number sign, but I'm old. So non-facility, the one that is blank, and that's where we're going to get paid for these individual services once the G0511 is gone. So remember, all of those things that made up the G0511 are now just our regular care management codes. These are all of the codes that apply. And we're going to take special notice of 99091 because 99091 is what we used to consider our virtual check-in. If we look at what the fee is under the fee column, that is the current 2024 Medicare physician fee schedule for that care management code. We've made note 2.3% reduction from 2024. So I put G0511 up there, but it should be 2025 payment for that care management code. And then the subsequent percentage decrease from G0511. So if you were billing a whole bunch of 99490s for your care management program, you're going to have a reduction. If, in fact, as most of us see, we're spending more than 20 minutes of staff time per patient, now we can go up and bill 99490 and 99439. So our net payment should increase. Look closely at this list of services because there's some interesting additions. Navigation services, community health integration, principal illness navigation. Some of those were already in there, but there's some interesting additions. We're going to talk about more of those. This care management change, G0511, is in place until July 1. If you can start earlier, you can go ahead and start billing the CPT codes. We can bill the care management codes if there's another payable service or not. But you do have until July 1 to continue billing G0511. We had asked to have care management service coinsurance waived. It was not approved. CMS does not have the statutory authority to waive coinsurance on any services. But just like I've always made Patty blanch a little bit when I say, hey, when we sign care management patients up, say there's a coinsurance, but you'll never pay. Joking, of course, we can't say that. Now what we can say is with CMS authority, hey, we need to be providing our own financial assistance to patients. Just because we're a rural health clinic doesn't mean you have to have a sliding fee scale, and FQHC does. But just because you implement a sliding fee scale doesn't mean that it has to match HRSAs. So have financial assistance available for your patients. Most of these are qualified Medicare beneficiaries anyway. We're going to talk about that. 2211, extra 20 minutes. That's still effective. We don't get any extra payment for it. It is an incident to service, just like an injection. Nothing changes there. So we can have these covered, but they're just incident to. They don't involve an extra payment. And again, CMS did not have the regulatory authority to change how 2211 works. So we're still bundling 2211. This is my only claim example. We necessarily would include a 99215 if we're doing G2211. But again, it just goes into patient coinsurance. It's not a separate add-on payment. That's what CMS is saying. And have the authority to make this a separate add-on payment for whatever reason. Incident 2. G0512 is unaffected. We still have G0512 in place, which is the psychiatric coordination of care management. G0511 gone. G0512, remember that's the elevated $170 psychiatric behavioral health, stays in place. Virtual check-in, gone. Virtual check-in is gone. G2012 has been replaced by that 99091, which describes a brief virtual check-in. I'm going to go over this more. G2025 has been extended. Get one more year of G2025 while we try to figure out what we're going to permanently do with visits. If you really want to read the final rule, it also includes a lot of commentary of why decisions were made and what the thought processes were behind either making a change or not. And apparently removing G2025 has a big budgetary cost to it. I don't understand why, but that's why it hasn't been made permanent. So boy, we've already been through a lot and we still have a lot more to go. So let's talk about this new service set. Advanced primary care management services. I'm not going to read all of this to you. We get and receive payment for advanced primary care management services separately from our encounter. These code sets, instead of having to keep time on them, are based on the number of the patient's chronic conditions. So think about the amount of time that we spend just tracking 20 minutes per clinical activity spent on a care management patient. Think about the time involved in that. It's a lot. There's a whole industry set up around care management services and software that will track that time. And advanced primary care management eases that pain a little bit because it's just for treating the chronic condition. Now, relative to the payment, we'll see how that looks. These are per calendar month bundles. Some of these services overlap with care management, so we are restricted in providing care management services and a couple of others at the same time as advanced primary care management. Here are the new codes. Here are the work RVUs associated with it and the new fees. Look at this one. Patient qualified Medicare beneficiary with multiple 2 or more chronic conditions. That's probably most of our patients. I had to question and go back and look what a qualified Medicare beneficiary is. We'll talk about that in a second. But $110 payment. So the advanced primary care management code, if we're doing a patient with multiple chronic conditions, a $50 payment. How does that look relative to tracking care management? Good question. You need to go back and look at your own practice. How much of that is a physician doing it versus how much of that is a clinical staff person doing it? But now we have added flexibility. We won't have to track the time for these. Qualified Medicare beneficiaries are basically our dual eligibles. There is a process with enrolling as a qualified Medicare beneficiary. And I don't know what that looks like. Somebody here probably knows better than I do. But we've got to redetermine that eligibility annually. And hey, for those of you that are in an ACO, something smells suspiciously like patient attribution here. So you get your qualified Medicare beneficiaries and an attributed patient, and I think you're cooking with gas on that particular line item. So as you're reviewing attributed patients, make sure they're also qualified Medicare beneficiaries. That is a good assignment for care managers. I'm not going to go through all these service requirements. The consent requirement is exactly the way it was under regular care management. We've got to let them know that cost sharing applies, probably covered by supplemental insurance. We have to document in the patient records that we've obtained consent. 24. Now, don't assume that all of these are exactly the same thing. I almost did. And I said, Charles, read more closely. And indeed, some of the language has changed in these service requirements. We still have to have 24/7 access to a care team member or practitioner or healthcare professional, continuity of care, deliver care in alternate ways. That's new. Home visits, expanded hours. That's a new. It says such as, not a requirement. Of course, we don't have any care management services of any kind if we don't have a comprehensive care plan that's available inside and to outside personnel alike. You all can read those on your own. All of this language generally mirrors what it does for regular care management services, and coordination of care transitions language is a little different. Enhanced opportunities to communicate through telephone access. Ongoing, this is important. This is a different one. Service requirement. Ongoing communication and coordinating receipt of needed services from other practitioners, community-based resources, and documenting that communication. Documenting that communication is the important part. Without the documentation, of course, we know it didn't happen. Asynchronous use of technology is part of these. And from the previous slide, this sounds like remote monitoring, doesn't it? Pre-recorded patient information, interprofessional telephone, internet, et cetera, et cetera. So make sure and look through those, but look what we've got here. For those of you that are in ACO, part of the service requirement is that you're analyzing patient population data. Real advantage, check. Stratifying risk for our practice population. Real advantage ACO, check. All of your ACOs are doing this. Measure performance of your quality indicators, check. So if you're in an ACO, you're already doing a lot of these things. And of course, that was the whole point of getting into an ACO now, is starting to obtain some muscle memory for our value-based and quality care initiatives. These are duplicative services. We cannot provide these services at the same time as advanced care management services. Concurrent billing says no. Some of these services, BHI, community health integration, don't test me on all these acronyms. Principal illness navigation, social determinants of health. These we can bill concurrently. These we cannot bill concurrently. Stay tuned for more rules. Patty and I talked about this a little bit, and a lot of this goes to documentation so that we're not using the time that we're documenting for one service, or the time we're using for care management could not apply to that advanced primary care management. So we can't overlap our minutes. We can't bill multiple units of care management anymore. Now we're going to bill 99490 plus each additional 30 minutes of staff time. If we have 20 minutes of general care management, we do have remote patient that should be maybe RPM or RPT, remote patient therapy. We can bill those together. There'll be a lot more conversation about those. Just wanted to put that back up there one more time. Those are our advanced primary care management codes. I'm moving along pretty well here. I'm going to keep going. Just one more time. These are now our care management codes, and with that 3% projected price. Telehealth, G2025 has been extended through 12/31/2025. Here's what we know. We had some flexibility granted us in COVID, and we could not permanently waive distance site originating site, but in 2022, we had what was the start of a foundational change where we had our encounter definition change to include behavioral health visits rendered via telehealth. So remember, we got behavioral health visits via telehealth as an encounter, but with that was an in-person visit requirement, which was waived. My point is the in-person visit requirement for behavioral health visits as encounters continues to be waived. Continue to waive that. Direct supervision via telehealth, still in place through 12/31/2025. This does not mean everything we want it to. For example, we could not have for rural health clinic compliance a physician only within direct supervision and not at the clinic in order to be open. But for direct supervision, it does include a virtual presence. I put these on here. Look at these new behavioral health codes. There's some interesting codes on here. Post-discharge telephonic follow-up. I put these in almost as an asterisk for you to investigate more thoroughly. This isn't necessarily part of the rural health clinic benefit, but there are new behavioral health codes out there. Mark, are you with us?
I'm with you. Yes.
You want to take us from here, and I'll go ahead and operate the slides?
Yes, if you'll do that, that would be great. Pneumococcal influenza and COVID vaccines, we're probably pretty familiar with putting those on the Medicare cost report. And the problem has been is that the typical process is in the summer, let's say summer 2024, you have to buy your flu, your pneumococcal, and your COVID vaccines, and they've become more and more expensive. You may be shelling out $50,000 to get those vaccines. And unfortunately, we're putting them on the Medicare cost report, and you file the cost report 90 days after, I'm sorry, 150 days after your year end. So that's in May. Then by September of the next year, Medicare gets around to actually paying you for them. And so you've got 50 grand that's been tied up for basically a year and sometimes 6 months, a year and 3 months in most cases. And on a small rural health clinic, that is very difficult. That makes it sort of a burden for you to be providing those vaccines. It's almost easier for you to say, well, just send them down to the drugstore and let them do it. So what's happened is CMS is proposing that starting in July, you will be able to bill fee for service for your pneumococcal, your influenza, and your COVID-19 vaccines. And they've added hepatitis B to the pot. Before it was considered an incident to service, and you really didn't have any way to pay for it or get paid for it. It would just become a part of your rate. They've called it out now to where you can bill it fee for service and get paid for it. You don't bill it to Part D to transact RX, like you would with a shingles or something like that. So it becomes almost exactly like your pneumococcal, influenza, and COVID vaccines, and they're going to rework the cost report to where we're going to put those services on the cost report. You're going to get paid 100% for those. There's no 20% reduction for co-insurance or anything like that. And so that's really going to be great. This will start July 1 of next year, where you can start billing for it. It will be settled up on the cost report. So there'll be a settlement process. We're thinking that you're going to bill on the 1,500 right now, but working through the mechanics of selling the cost report. I'm thinking they may change it to a UB04 in the future, because they'll want to have those payments on a PSNR report, which I know this is getting sort of in the weeds, but that's in the future. I think what we need to know now is we're going to have a much better, faster way to get paid for these vaccines that we're providing, and these services. We need to be providing these services for these patients. It's going to help our quality. It's going to help keep our patients healthy. And so that's going to be important. So I don't know, Charles, you got any more on that? Is that
No, I think
okay?
it's a great thing that we don't have to wait for that money.
Yeah, you don't have to wait for the money. That is the big great thing about this.
Mm-hmm. Want to go there?
Yeah, productivity standards. This is a really good thing too. In fact, I had a meeting with about 5 doctors right before we got on here, and they had been hit with a productivity screen that cost them $35,000 on their last cost report. But going into the history of this, since I guess 1982 here, as a full-time physician, you should be seeing 4,200 visits a year. That's 40 hours a week, 2,080 hours per year. For a nurse practitioner or a PA, the minimum productivity is 2,100. What that means is you don't lose your RHC certification if you don't hit those numbers, but when they calculate your cost per visit, which is the cost per visit calculation, is your total expenses divided by your total visits, unless you're not meeting your productivity standard. And if that's the case, they will use that higher productivity standard. And what does that do to your cost per visit? If you lower the denominator, or if you raise the denominator higher, it lowers your cost per visit. So that can really hurt you on the cost report if you have low volume. So that's going away, and that's a great thing. That means, like I said, this clinic this morning, they're going to get $35,000 more the next time they file their cost report because of this. Now, does that mean that you don't have to keep up with some statistics for your visits and all that? Not necessarily. We're still going to need visits. Typically when we do a cost report, we're going to ask for a CPT frequency report, and we're going to ask you to break it down by provider. We will probably keep asking for that for at least a little while, because on the cost report, you have things that aren't covered under the all-inclusive rate. Things like if you go to the hospital, that's not a part of the Medicare Part B, the all-inclusive rate. That's billed to Part B. If you have private practice time, chronic care management, all sorts of services that you provide that aren't a part of the all-inclusive rate, that whoever's preparing your cost report is going to have to figure out a way to allocate or reclass some cost to that area. So we're probably going to need to know, did a physician do it? Did a PA do it? Or did a nurse practitioner do it? Because we're going to use a 300 grand salary for a physician, 150 grand salary for a nurse practitioner or PA. So don't throw away, all of the, all the statistics at this point. I mean, we probably can do less statistics on keeping up with, the locations of the physicians and the nurse practitioner and PAs if they're going into like meetings and things like that. That sort of stuff we won't need in the future, I'm thinking. So I think the key to this is stay tuned, stay in touch with your cost report preparers. They may have different thinking about this, and we're going to learn as we go on what Medicare really needs, because they're going to be changing the cost report forms next year. They're going to have to change them because this goes into effect for cost reports ending December 31st, 2024. So if your cost report ends, the fact that the client I talked to this morning, they were a March 31, 2025 year end. So that's great for them. They are no longer, their productivity standards do not apply to them now, so they don't have to worry about it. So that's the two things that you got for me, Charles.
Hey, keep in mind, the productivity standard is the break even effectively, right? So if you're not watching your break even, what are you watching?
Yeah.
So
and really, and actually, I think the minimum productivity standards really won't even get you to the break even. The way my experience with clinics in the past is for this small physician practice. If you've got a physician, they got to be seeing 25 to 30 visits a day before. But it's the happiness standard. You get to where you can pay people what they feel comfortable with. And for a nurse practitioner, if you look at the standard, if that's 7 visits a day, let me tell you, I was at a clinic yesterday, and she was seeing 5 visits a day, and we were not at the happiness standard. You got to do like 15 to 16 per day to break even. So 30 for a physician, 15 to 16 for a nurse practitioner PA.
So don't stop watching your break even.
Yeah, that's right.
Effectively what that is. Mark, thank you very much.
Yeah.
This, again, we've already talked about this a little bit. Goes into great detail in the final rule about the market basket. These are the weighted averages that changed. And this is an extremely dense section, but ultimately that's what it boils down to. I'm not going to touch a ton on our dental services, but just know that because dental services are mostly routine, in order to get anything paid under the Medicare statute, it has to be related to a medically necessary service. So we've got some modifications to the encounter change. So we'll get an encounter paid for dental services as long as it's inextricably linked to a covered service. And that would, of course, be something reconstructive due to an accident or illness. So a lot of us this is not going to apply to quite yet, but stay tuned for you FQHCs. Here is what is easy to say, but gosh, this is going to save so much angst. Just was talking to somebody that they had to shut down their behavioral health and substance abuse, close their doors because they had breached the 51% primary care rule for being primarily engaged in primary care. Long and the short of it, the rural health clinic statute said rural health clinics cannot be primarily for the treatment of mental diseases. It's in the statute. Surveyors were guided by Appendix G, which told them, this is an interpretive guideline, that they had to measure 51% of provider hours to make sure we're in compliance with that. So it was kind of made up. Made up in the sense that it was not in the statute, and 51% of total provider hours is not in the statute. So CMS is no longer going to enforce the standard of being primarily engaged in primary care services and would no longer consider total hours of RHC operation and whether a majority are primary care services. All we need to do is provide primary care. Now, there's a fluke in this that caused problems for FQHCs. So FQHCs are actually exempt from this. So sometimes they may have a site that is only behavioral health services for them. And so some of their structure can be quite a bit different. So FQHCs have a bit of a waiver on this. Same rule applies. We still, every Suboxone patient you have or medical assisted therapy you have needs a primary care write-up in your chart. Don't have, in my view, my recommendation is, even though this is waived, we are still primary care. Don't treat solely psychiatric conditions so that that problem is gone. Medicare had proposed to define mental diseases, and everyone else thought, oh no, that sounds horrible. And so the proposal to define mental diseases was changed in favor of just enforcing primary care. Kate, are you with us?
I am with you, yes. And very excited to talk about that laboratory change. That's a little change for now, but it helps a whole lot. We have all those people buying their devices to do hemoglobin or hematocrit, which you will not have to do any longer. So that is really, really wonder. January 1st, and no longer will you have to do fecal occult blood, which was really a challenge for our pediatric practices because they don't do it that way. So this is gone in January. So we're very, very happy about that. More to come, we hope. But those are the first two of that list. We hope one day it says lab services as appropriate. You pick them like you pick your emergency box. One day, but not yet.
Small steps, right?
All steps, you bet. So that is gone. Oh, primary culturing also for collection of specimens has been changed to the language for culturing has changed to collection of patient specimens. We always thought it meant drawing blood anyway, so we're not seeing that as a major change.
Hey, Kate.
Yes.
I didn't know it meant more than just drawing blood or taking the sample. Well, I've been doing this for 32 years, and I learned that my non-clinical mind, primary culturing, was not what I thought it was. So,
well, you could swab a wound and send it for culturing, but most people draw blood. We call that primary culture. We're good.
That's why it takes a team.
Pardon?
That's why it takes a team.
It does take a team, especially with the federal government. Yes.
Would you like to comment at all on the primarily engaged?
I am still, because in the language of the rule, it did say we still haven't decided on the definition of mental health. And so there's that bit about primary care. But I can tell you this, it certainly eased that standard. It is a challenge for us when we see a lot of mental health in towns where it is desperately needed. And they're doing the right thing by caring for those patients, especially in some, very heavy drug addicted areas. And so we're not going to be looking at any of the other specialties at all. You just still, like you said, you must be primarily doing primary care medicine, and we're going to tread lightly. I suspect that the CMS is going to comment on that mental health piece.
Great.
Thank you. Charles, can I just say something?
Please.
Put the what I always call drop the turd in the punch bowl. For if there are any Louisiana clinics or any other clinics that are in a licensure state, which requires additional licensing, the Louisiana licensing law is still going to have all of the 6 required labs in it. So even though we're okay on the CMS side, we are out of compliance with state licensing law. The same thing for the primary care language is not the same as what is in the final rule. So we have to go with the higher of those standards. Kate and I were just at LRHA last week. We had this discussion. We got it right out of the horse's mouth that Louisiana clinics will still have to do all 6 tests, especially if they fall under the state agency for their research.
Excellent. We're going to talk about intensive outpatient program services for us.
Yeah, we can jump in on that. So, and I was going to ask you, Charles and Mark, I don't see very many IOP programs being carried out in rural health clinics.
Mm-mm.
And there's a reason for that. It is an intensive outpatient program. It has very strict criteria. It takes space, it takes time, it takes a lot of resources. And I've been getting a lot of calls this week actually, now that the final rule has come out, from people that are very curious about it, and people are trying to form alliances to create IOP programs. And so you really just need to understand what it is. It is really a step down program in most cases from someone who has had inpatient psychiatric care. They have to have an Access 1 psych diagnosis to qualify for IOP, and they have to be certified by a physician that they need the program. I don't know if I'm getting ahead of the slides or not.
It's okay. We're just kind of talking through it.
Okay.
So,
So yeah, so it includes all of this. And this is not going to be found in our RHC, our FQHC Chapter 13 benefit policy manual. All of the specifics are going to be in the benefit policy manual Chapter 6, which is the outpatient therapy. So
ah,
it's not for the faint of heart to do all this. And IOP programs, as long as I have been in healthcare, have always been under the magnifying glass because people try to put one together. They don't have it. It's supposed to be very structured. It can't be mainly recreational. We had a place in one of the towns that I worked where a facility was sending um, a bus to Walmart and picking up a bunch of people at Walmart and taking them to their IOP program, and they were doing arts and crafts and eating donuts. So that definitely did not qualify for it. So these are also paid on a per diem rate. So and anything in a rural health clinic that does not pay our AIR is a carve out. So you've got a lot of resources that have to be put towards these intensive outpatient programs. And yeah, we're going to have to be able to separate that space and carve out those direct expenses. So it's a big challenge. I think it's a great opportunity in parts of the country where we really need these intensive outpatient programs because they do include substance abuse disorders as a diagnosis. So, uh, and we can't have a medical visit and an IOP visit on the same day, which is great for some of those patients. And then Charles is showing you all of those codes for
so to
those.
Patty's point, it can't just be, you know, recreation. It has to be 4 of the services listed in this table that qualify, that then you can bill for the $413 we just referenced once we have any 4 of these activities. Am I saying that right, Patty?
Yes. So in the original regulation that brought RHCs into the IOP world, it promised us that RHCs would be paid whatever the current reimbursement is under other outpatient reimbursement. So we're going to where now we can have 4 or more services. So it's kind of increasing that level. But these are very structured. Every patient has to have an individualized care plan and treatment plan. And they have to be able to obtain reasonable milestones in their care. So this is a great slide for that. And it is at least 9 hours per week. Now, we can do some group activities in an IOP, but again, the IOP is paying a per diem, a per day amount, and not our all-inclusive rate. And so again, anything that doesn't pay our AIR and Mark, you can jump in if I'm saying it wrong, but basically, if it doesn't pay our AIR, then we can't put those costs on our cost report anytime we get something paid by a different methodology. So if you have the space, if you have the time, if you have the staff and the resources, it's a great thing for you to do. Now we are on par with everybody else that has an IOP program as far as being able to offer 4 or more services a day. It's just a big challenge. So I would direct you to the CMS Benefit Policy Manual, Chapter 6. We usually go to 13, but 6 is where you're going to want to read how much structure there has to be. This is not something that you throw together. And if your RHC provider is asked to participate in somebody else's IOP, they can't bill their professional fees. The professional fees for all of those practitioners are included in that per diem rate, which I think Charles had a slide of what the benefits, what was all covered in there. So just be careful if somebody approaches you that you're getting into an arrangement that is a win-win for everybody.
Yeah, Patty, this is Mark. In a past life, I ran a company that did geriatric psych units back in the 90s for 4 hospitals, and it is quite an undertaking. I mean, we would typically rent a modular building, a trailer, put it outside the hospital. We would end up renting vans to go pick up people. You'd have to hire drivers to go get people, and then you have a whole LCSW staff and your psychiatrist that would be involved in it, and then the space involved. Most of these rural, if you're an independent RHC, there's huge hurdles, and then once you've got through all the hurdles, then you do have the great, you're getting $424 or $413 a day, but you could be tanking your $139 rate from medical services as well. So I've really not seen a whole lot on the independent side. Now, if you're provider based and part of a hospital, you're probably talking to the CFO and figuring out which way is it better. Should we run it through the rural health clinic, or should we do some type of other way to get paid for this through the hospital, which I don't know what those are. It's been since 97, so there's a hospital cost report. But those are some of the questions that you need to ask before you do this. And like I said, I have not seen a whole lot of independent RHCs even think about having the space or the ability to do these projects.
The other thing I would add again is some states have different ways that they enroll and license outpatient mental health programs. So again, we want to make sure we're not running up against a state regulation. Even though CMS allows us to do it, there might be some extra step or some limitation on the state side.
I think one thing that always comes back to me are the number of CEOs and critical access hospitals I talk to that have bed space being taken up by behavioral health patients. And perhaps this can take some pressure off there too.
True.
Good. Well, thank you both very much for that input. This is a program I don't understand very well. So again, takes a team, right? Speaking of teams, I know the team that is responsible for this, and great work. So National Association folks listened. CMS finally listened to us of why we want to submit CPT2 codes on a UB04 and effective April of 25. We no longer have to split bill our CPT2 codes for rural health clinic or FQHC. We're going to be able to report those on a UB04. And here's why I think that is so important. We're a billing company. Anytime we have to touch a claim, we lose. We don't have enough margin on any of our claims to touch them. So when we have to go out and split bill a CPT2 code and have an extra touch, we're costing ourselves money every time we report a quality indicator. So to me, this is an additional streamline, one less touch, no different than getting secondaries to go electronically. So to me, this is huge. So great job, National Association, getting this done. Big deal. Somehow we made it through 117 slides in less than 60 minutes. It's because we're all professionals here. So this is a bit of a summary to reiterate the fundamental changes that we just reviewed. Count on additional rulemaking on many of these. But hey, this is an example where CMS listened to us. And when you read their comments, they listened pretty closely. So I wish I had Patty's Medicare Benefit Policy Manual, Chapter 6, did you say for that on the outpatient program, Patty? Chapter 6?
CMS Benefit Policy Manual, Chapter 6, which is the outpatient services manual. It has quite a bit in it. And guys, we just got guidance on IOP and care management from last year in September of this year. So sometimes this guidance doesn't come out very quickly.
And nothing going on in DC. So who knows what we might see regarding duration. So I had a couple questions up here. And first of all was from my colleague, Daniela Yusuf-Bekova. I challenge anyone to say her name quickly 3 times. And remember, of course, we have 50 different Medicaid programs. Daniela's question was state, which I happen to know she's in Florida, maybe she put it in here, is still using a face-to-face definition for allowable visits and will not pay for care coordination services. This is, of course, Patty, you've got some connection there in Florida, but this is where we have to communicate these and keep, at the beginning in this, I put up and I emphasize, I meant to call it out, that this is the Medicare and Medicaid update. So in Illinois, we're having a huge problem with our state Medicaid agency rebasing our rural health clinic encounter rate. So we have to stay after our Medicaid programs to keep pace with these. It is to their benefit to pay care management services. So my suggestion, Daniela, is, in your case, whether or not we go through the state office of rural health, but to lobby your state Medicaid agency to get more broadly implemented our care management services at the Medicaid level. My colleague Kelsey down in Sudan, Texas, I got to go visit Kelsey. Kelsey and Sudan Medical Clinic are doing the deal. That's what we're here for. Rural Health Clinic outside of Muleshoe, Texas and Sudan, Texas. But they've got a great clinic and some really great minds down there providing excellent patient care. We're really, really proud of them. Would we be able to charge more than once a month for 99490? No. But you can do 99490 plus the additional time. And we still have some rules to propagate about whether or not particular providers, if a different provider does a 99490, whether or not it's billable, I don't think it ever will be. Finally, I see Miss Anonymous out there who wants to know if the slides will be available. Of course, we'll post these slides out on the Rural Health Clinic Information Exchange website, Facebook page. And let's see, can we get Elon Musk to streamline Medicare reimbursement processes? That would be maybe watch what you wish for, but I'm probably not the best person to comment on those. And will there be, but hey, we do have a new government agency named after a Bitcoin. So there you go. Yes, we'll send out slides, grace period beyond July, retro billing. Hello, my friend Anita. And no, the July through July is the grace period. And yes, I hope this was recorded and that I'll be able to post this recording out there. Sometimes I don't hit that button just right. Thank you so much for everyone who has attended. I always like to say the worst question is the one that goes unasked. One more thing I want to say. Everything we just went through, we didn't even touch on any of the shared savings changes. So there are a whole raft of changes to the shared savings / ACO program that we didn't touch on that my colleague Daniela will help us all sort through. To my colleagues, Kate and Mark and Patty, thank you so much for attending. I know you're traveling and have your own schedules. I appreciate you being here. I'm sure all of our viewers do. Any parting thoughts?
Yeah, I want to add a thought. I had a question that someone read, and I have not found it, that the mental health provider does not need to be licensed in the state where the patient is on telehealth. I cannot back that up. I don't believe it's true. But do either of you know, or Mark? Either of the three of you know.
So Kate, say the question again.
A mental health worker can be licensed in Pennsylvania and do a telehealth to a rural health clinic in Ohio.
That's going to be based on state board regulations, but typically you have to be licensed in the state where the patient is for any services.
Just like our medical directors do.
Yeah,
I agree. Somebody told me they read it. They can't find it. I certainly can't find it. And I thought I'd ask since we had the trio here.
Yeah, Kate, what I would do is look for the Center for Connected Care. They keep up with all these regulations, and they put together a little booklet every year about what the state regulations are on telehealth and all that. And it is in there somewhere. During COVID, that was like the Bible there for a while.
Thank you. I do not know that. Is that a federal organization?
It's a federal organization. It is. And they put out great material, great webinars, great publications. Oh my goodness, they're very good.
Learn something new every day. Thank you,
Center
Mark.
for Connected Care. I do too. I do too. I was in a clinic yesterday, and the guy up there told me something, and I was like, I did not know that. I've been doing this for a long time.
Also, I would check with the state licensure board for whatever that discipline is, because that's gonna be where it's gonna originate from.
That's always the first stop, folks. When you read something on a listserv or on the Facebook page, you must check with your state.
Big time.
Yeah, just because it might be true in somebody else's state, but not in yours, and that's really, really important.
Ronald Reagan, trust but verify, always. I am probably not good enough at this, and I see my colleague Lauren Kidd has a question. And Lauren, you can try to talk, but I don't think you'll be able. Oh, here's Lauren. What about LPCCS billing being on site? Licensed professional counselor. And that
I think they're talking about maybe she's talking about when they're being supervised, when it's somebody that doesn't have all of their hours and they're being supervised. Maybe it's a question about incident 2 billing under the supervising counselor. Maybe. Lauren, I don't know.
Hey, Lauren, you and I can follow up separately with one another and get that answered for you. You know where I live. And then Scott, I think we answered your question on CMS Medicare Benefit Policy Manual, Chapter 6 for the IOP rules. Well, everyone, thank you so much for attending today. This is why we're all here, and it is about delivering care to our patients. And I'm proud of the role we all play in that.
And Charles and Mark, don't y'all think that when we get more guidance on these specific billing questions, we will be doing future webinars to give claim examples and clear up the mud?
Yes, ma'am.
And thank you, Charles, for putting this together, and Mark and Patty. Wonderful. Let's keep our eye on the ball and stay in touch.
Thank you, everybody. Have a good rest of your afternoon.
Thank you. Bye, everybody.
Bye now.